some of the most frustrating posts that I see, it's often like, oh, I'm really craving a soft serve ice cream from McDonald's. Like, is it really that bad? Why do I have to avoid this? Isn't it just better if I have it because I'm craving it, or whatever that language is around that? And I don't have a problem with that question per se. What I have a problem with is then the people in the comments being like, I ate whatever I wanted in my pregnancy and my baby's fine. Oh, our mums didn't do this, blah, 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 blah. All these different survivor bias type of stories. And I appreciate all that. But whilst it's very uncommon for people to get sick with listeria or get sick with salmonella and it cause a pregnancy-related complication, the risk-reward ratio just like is so off that we just go, let's just be a little bit more conservative here, just in case.
Welcome, Steph. Welcome to All About You. I'd love to begin by asking you a little bit about who you are and how you've ended up where you are today.
So my name is Stefanie Valakas, and I am a Sydney girl, born and bred, as you can probably hear in my voice a little bit. And I come from a Greek family. I grew up in the suburbs of Sydney, and I think I was going to be in the world of nutrition from about maybe 15 years old or so. And maybe I didn't consciously know, but looking back, it's really funny because some of my friends from high school were like, you were writing meal plans in your lunch break for all of us because you were appalled by how terrible our diets were. And I was like, which 15-year-old's diet is any good? Let's be real. And I just went, oh my God, I don't remember that at all. But I remember absolutely I loved school. I was really good at school. I was really conscientious and a bit chatty and I had a cheeky side to me, but I never really got into much trouble. And I think it was probably my final years of school I really found a deep love for science, and also I had a bit of a interest in history and English and things. So I toed and froed about what I was going to do for a career. I came from a family where no one really went to university or pursued tertiary education or had a career that was kind of mapped out for me. It was all kind of do what you like and we'll support you kind of thing. So, yeah, I think the science part really, really interested me, and I really started to learn more about health. And I think it was medical physics that I did at school that I really loved. And I thought, and my best friend wanted to be a doctor. And I thought, I don't want to be a doctor. I said, you can be a doctor. I don't want to be a doctor. And she said, why don't you be, I think she said it. I think she said, why don't you do something with nutrition? Like, you love food. You could help people's health with food. And I didn't even really know that was a job. So it wasn't until I showed up on the open day at Sydney University and the head of school was like, this is what being a dietitian's about. This is the degree. And I just went, sign me up. I'm going to do that. Before that, I thought I'd be a scientific researcher. And I had a lot of pressure at university in my early years to go into research. And it wasn't, whilst I appreciate and respect research, I couldn't imagine my life in a lab or sitting in an office doing research. And so I really channeled that kind of clinical energy. And so, yeah, that's probably a little bit about how I ended up selecting dietetics. I just didn't love the lifestyle element of being a doctor. and I can say that with a lot of respect for doctors, because I have many very, very close friends of mine who are. And I wanted to influence people in a different way that didn't involve medication in particular. Not that I have anything against it, but I wanted to leverage food. And I think that's what I was really passionate about growing up, and in the context of being in a Mediterranean family, I think, as well. So, yeah, the love for fertility and pregnancy really came backwards out of a love for pediatric nutrition. So I was in children's health, and I thought that was the forefront of preventative health. Help the kids won't get sick later in life. Everyone's happy. I had this very aspirational view that, we could prevent all these diseases. And to a degree, I still hold that aspiration of affecting the next generation's health. But I realized that preconception and pregnancy nutrition was really where I was able to make more of an impact. And I really appreciated the technicality of it, which I think is often overgeneralized a lot. Nutrition can be an extremely technical field. And we often boil it down into eat your fruits and vegetables, drink water, don't eat chocolate, these very broad and sometimes obvious recommendations. But nutrition, the science behind nutrition and the art of recommending is extremely technical, and we make it look easy, and that's when you've got someone good. So I think all those things really, really interested me and kind of drew upon all the skill sets that I was really enjoying. But I mean, my alternative career choice was to be an archaeologist. So I'm full of dichotomies like that. So yeah, I think a lot of healthcare professionals will probably say something similar, like it'll be something creative or historical or artsy or completely different to what they're doing now. So yeah, that's probably a little brief overview of me growing up, where I'm from, and how I got to dietitian land and fertility dietitian land.
Amazing. And so if someone wanted to come and see you, what would you want them to have done before they come to have a consultation with you?
Yeah, I love that question. Thank you for asking it, because that makes my job so much easier. What I love to see from my clients before they come into a session with us is any pathology results that they may have, or if they haven't done some in ages and they do have a health condition, or they're trying to conceive, that they've had a conversation with their GP and gotten some relevant lab work done. A lot of what we do is founded on the lab work, and the less visibility we have of those, the less kind of individualized we can be. And the more data we have, the more individualized we can be from the get-go, and it avoids slowing down your care in terms of, we need to now wait to the next consult till you get the opportunity to get your labs, and then we can do X, then we can do Y. So things like having your iron results, your vitamin D, thyroid function is often a common one that we're looking at, celiac serology, and then, more condition specific. So if somebody has PCOS, we might be looking at liver function and cholesterol and insulin resistance and glucose markers. And somebody has endometriosis, maybe looking at more inflammatory markers. Or someone who's going through IVF and it's not working, you might be looking at some more autoimmune conditions, or looking for kind of an X factor there. So it really does depend on the case, but in general, certainly some nutritional lab work is really helpful. And if you're ever unsure, you can always ask us and ask your doctor as well. And I think that's always a helpful place to start for most people. You don't need to have done a food diary or any of those things. I know a lot of people feel like that's the way, but I personally find that I actually get better data, a better picture, and a more realistic picture of how people eat by letting me ask the questions that I need. It takes about 15 to 20 minutes of the consultation, but I get a much better understanding than your food diary. Food diaries are great, but as someone who recently decided to do this experiment on myself, you will leave things out, or you will eat differently because you can't be bothered recording it. And so as a result, it doesn't really perfectly, and nothing perfectly, but doesn't really reflect how you're truly eating. So a dietitian will be able to get everything out of what you're eating with the consultation. So you don't really need to do that. And if you've got a GP care plan, for example, chronic disease management plan, bringing that along as well is really helpful, so we can get that set up for you and you can access some rebates.
And sometimes people think that they only need to see allied health or a doctor if there's something wrong. But in an ideal world, would you love to see every person, every woman preconception? Like, that would be the ideal, wouldn't it, really, to optimize for everyone?
Yes, that is absolutely correct. Our vision at the Dietologist, every hopeful parent will access expert nutrition support. And I know that's an ambitious goal, because I think there's, I can't even recall how many thousands and thousands of births there are every year in Australia. But I think ultimately for us, we try and reach people in different ways. And obviously consultation is kind of the tippy top of the pyramid, where you're getting that one-on-one, highly personalized advice. And irrespective of whether you think you have an issue, don't have an issue, unsure yet, healthy couple just trying to conceive. I think I've never had someone even who's healthy, just want to do the best, who walks away and goes, oh, I learned absolutely nothing. That was useless. You always come away with something. And I also think ultimately we do lots of things to help protect our children. People will delay cord clamping. People will freeze cord blood. People will do all sorts of things to safeguard their child's future and their child's health. And this is actually the very first thing that you can do to try and safeguard your child's health and your own pregnancy health, because of the impact that preconception, lifestyle factors, health factors, dietary factors can all play in the risk of pregnancy complications. And genetic programming through something called epigenetics, so not actually changing the DNA code, but the way that DNA is expressed, can actually program in your child's lifelong risk of certain health conditions, chronic conditions, heart disease, type 2 diabetes, allergies, eczema, asthma, obesity. So we're talking about, huge burdensome diseases that society is now dealing with in hospitals, in clinics, and everywhere. And I think we need to have that conversation. It's not a guarantee, it's a risk reduction strategy, but it's to change your diet and lifestyle for that potential positive outcome. It feels like a very small price to pay when we're paying much higher prices elsewhere. So I think it's just also for us at the Dietologist, yes, it is about consultations. Yes, it's about individualized advice, but it's also just getting the message out there about it. So raise the societal awareness about how important this is and how much of an impact it can have beyond fertility, just talking about health. And I think that is the key for us and for a lot of healthcare professionals as well.
I think we've done very well really over the years in convincing people about taking their folic acid and reducing the risk of things like spina bifida. But I feel like it probably ground to a little bit of a halt after that. And I think people aren't really aware of what health conditions they can influence by, changing or improving their diet. Would you be able to give us a couple of examples that our listeners might be able to put into practice?
In terms of conditions that may be amenable by diet from a preconception health and fertility standpoint, yeah, absolutely. We will start with I would start with the reproductive health category. So things that may affect your fertility or affect the health of the pregnancy, for example. So the most common ones that we see are polycystic ovarian syndrome, or PCOS. So it's a cluster of symptoms that typically manifest as irregular cycle, which is kind of usually the main barrier to conception for PCOS. But it also can result in hair thinning, acne, and excessive hair growth in places like your chin, your jawline. Sometimes people have more hair on their arms and legs or chest or tummy and things like that. It's called hirsutism. And you may also have what's called polycystic appearing ovaries, which isn't necessarily cysts as we think of a cyst. It's actually follicles that can't quite develop fully. So polycystic ovarian syndrome, or PCOS, one of the most common reproductive health concerns that we see, and it's also one of the most common affecting fertility. And we know that diet and lifestyle can have such a significant role to play in PCOS management. We can actually, using diet, lifestyle, supplementation strategies, can actually get people's cycles back to completely regular. I've had clients with all their symptoms disappear, the ovarian morphology completely reverses, and thankfully, we're seeing more acknowledgement of the role that dietitians can play in PCOS with the release of the latest International PCOS Management Guideline by Monash. And I think that just continues to highlight it. There is this hyperfixation on weight in PCOS because many people with PCOS will struggle with higher body weight, and they may also struggle with insulin resistance, which is a much higher statistic again. But not everybody with PCOS will be in a large body. And also, weight is, you can independently improve your PCOS management with diet and lifestyle without necessarily changing body weight either. And the last guideline also highlighted this, which I was really thrilled to see. And so that's one way, that's one group of people. Another group of common people is endometriosis, which affects now, what's the latest statistic, 1 in 7. And that's a inflammatory condition. It's chronic in nature. it typically causes pain, but not always. One of the most common symptoms that I see of endometriosis is actually infertility, and a lot of people don't find out that they have endometriosis until they are quite far down the path of trying to conceive. Endometriosis is a physical growth, however, so sometimes surgery needs to be involved as well. But nutrition may not be able to stop the progression of the disease or stop it from occurring or reverse it, but we can reduce the amount of inflammation in that environment, which may be negatively affecting the quality of the eggs. It can actually even hurt the sperm coming in if you're trying to conceive unassisted, and implantation. So nutrition is a really important factor there. And then we also have hypothalamic amenorrhea, or sometimes called HA, and that is a suppression of ovulation due to typically under-eating, so not enough energy in, over-exercising, too much energy out, and chronic stress. You either get 1 to 3 of all those factors coming into play. This is extremely common, and it's also commonly misdiagnosed as PCOS because sometimes these women also happen to have lots of follicles, and so they qualify also for a diagnosis of PCOS, and then they try and lose weight or try and eat really low carb or something that they've read is good for PCOS, but they're actually making their hypothalamic amenorrhea much worse. So the aim of the game with people with HA is really to get that period restored by ensuring they're eating adequately, a wide variety of foods, helping them with any dietary restrictions. Many people with HA also have an eating disorder, but not everybody, but a lot of people do, and helping them to ovulate. I mean, anovulation is such a big part of fertility concerns and preconception health. Then other ones that people commonly don't think a dietitian could help them with in light of fertility, but we can. Thyroid diseases, Hashimoto's, hypothyroidism, Graves', they all have nutritional implications and symptom profiles. Celiac disease, inflammatory bowel disease, also diabetes, bariatric surgery if you've had that before, IBS. There's a whole host of conditions that come into play, and sometimes they are, really commonplace, and sometimes they're quite rare and weird and wonderful, as I like to say, but not weird as in like a shamey way, but just, you wouldn't see that every day. And there's a whole host of those reasons. And so if you've got maybe one of those things going on for you, you suspect you do, then those people need to come in. And probably another cohort of people that I would really encourage as well is anyone who's following a vegan or vegetarian diet. That's particularly pertinent because there are just so many nutritional gaps, and you will likely need more monitoring nutritionally and likely more supplementation as well. Folic acid will definitely not cut it if you're vegan or vegetarian.
Okay, and what about the male partner? Would you like to see them as well?
In an ideal world, absolutely. Male fertility is something that I'm kind of seeing more attention about. I'm seeing more attention, maybe not enough action. I don't know. It's an interesting time, but we're seeing sperm counts and concentration and overall sperm quality declining. I think, I can't quote the statistic perfectly, but I think it's like men of today have 30 to 50% less than their grandfather's sperm. It's in that realm. And we'll see some kind of media articles being like, oh, by 2040, there'll be no sperm left. We'll just go to zero and we'll just die out as a human race. And I don't know if that will happen. Like, I don't have a crystal ball, but I mean, it's trending down and quite severely. And that cannot be a genetic issue because you can't change genetics like that in 2 generations of people. It's obviously lifestyle, and there's lots of different factors involved in that. But male preconception health is so important for a variety of factors. Sperm health is one of them. Obviously, that's 50% of the DNA that's going to become your future baby, so we want that to be good. Men have a distinct advantage in that they get a refresh button on their sperm production every few months, and they can get almost like a clean slate again. That doesn't mean that you can't have a long-term impact on your reproductive health by doing some things. You absolutely can. There's many examples of this. Steroid use is one of them. Some kind of trauma to your reproductive organs will do things like that. You have a variocele, things like that. But for the most part, the vast majority of male factor infertility that we see is correctable with a lot of lifestyle strategies, and the data seems to support that. So that helps from a conception standpoint. But I think a lot of men, and I think we've done maybe not an excellent job at this, like from more of a public health perspective, we've kind of treated men in the conception picture as a bit of like sperm donor. Like, you're just here to give me sperm. And obviously that is kind of true, but it's actually not the whole picture. We actually know that the health of a future dad before he becomes a dad is quite correlated to the health of his child, whether that be genetics or through role modeling or both. And we're also starting to understand that a lot of miscarriage risk is not necessarily linked to maternal health, but paternal and what the sperm is doing. And even certain diseases and disorders that we're seeing at higher rates are associated with dads who are older, not just mums who are older. So all those factors are particularly relevant and important. And I think men have more of an opportunity to get a clean slate than women, but most of them don't take that opportunity reproductively to do that. It is a little bit frustrating as a clinician because, I sometimes speak to people who are, jumping through every imaginable hoop trying to optimize their fertility and reproductive health, and their partners, going to the pub and sinking 24 beers on a Friday night, and they feel really frustrated by that. And I can share that frustration, but I've also learned to kind of detach and be like, I can't make anyone do something that they don't want to do. And that's not on me to get them to come to the party. So ultimately, with anything lifestyle related, you cannot force anyone. You can lead a horse to water, you can't get them to drink. I can't eat the food for you, so we need to make sure that people are interested and invested. But I would say that's increasingly now the minority of men. I think now, as time's gone on, there's more chat about it. I think also just age, like new generation of men in relationships who they're going to try to conceive and things like that. Increasingly, I'm seeing men in consultations, and increasingly, I'm also seeing men being the ones initiating wanting to work with us, which is super cool. Like, I've been listening to all these podcasts. Can me and my wife come and see you? So we love to see it. We absolutely love to see it. In an ideal world, yes, just like a fertility specialist wants both conception partners in the room for their assessment. Yes. Does it happen most of the time? Not most of the time, but it probably happens a lot more than what it used to.
Yeah, it's improving. I would agree. I definitely have more couples who come together for the first couple of antenatal appointments with the GP, which is, I absolutely love that as well. I just think it just shows such an investment that it's not just the female partner who's pregnant. It's like, that both partners are really invested, which is so good. Okay, so the patient or the person has fallen pregnant, and we can sail through pregnancy, or we might go down that route, which unfortunately I did, which was hyperemesis and being really, really sick in pregnancy. And I just wondered if you had any hints or tips for anyone who is struggling with those awful first few weeks that can feel pretty miserable and can be much more than a few weeks of feeling extraordinarily nauseated, vomiting. Most women will describe an intense fatigue that doesn't even seem to make that much sense whenever their baby's the size of a jelly bean. But I'd love to know if you have any little hints or tips that are helpful at that time.
Yeah, absolutely. I think I might put hyperemesis in a slightly different basket, because usually anything you suggest for hyperemesis, someone's like, I did all that and it still didn't work. And that's just hyperemesis for you. You can only try. So, nausea and vomiting in pregnancy is a big spectrum. You can get people with absolutely no symptoms or extremely mild levels of nausea and no vomiting. You've got really persistent and intrusive kind of levels of nausea. And then you get people who are nauseous and vomit. And then you kind of slide all the way up the spectrum to hyperemesis, where, it's persistent and dehydration occurs, as electrolyte dysregulation and all sorts of other things. So there's a slider that we need to keep in mind. I think the biggest issue that I see clinically is that, particularly people that we work with at the Dietologist, is that these are often proactive, health-focused individuals who want to do the best that they can. They know that this is important and they value it. So when they get pregnant, and I warned them, hey, your diet isn't going to look like this once you conceive, because you won't be able to eat salmon and spinach and tomatoes and brown rice for dinner. You just won't want it. Like, they're like, oh, okay. Like, they can acknowledge it logically, but when it starts happening to them, they're like, I know you told me, but I don't think I actually believed you properly until now. I'm experiencing this nausea, this fatigue, the food aversions. Why does everything smell bad? The list is kind of endless. And I think it's mostly about expectation management more than anything else. I always tell my clients, trimester 1 is about surviving. Try and keep your prenatal vitamin down. That's your micronutrients. If you get a good prenatal vitamin that we've sorted out for you, tick. You don't have to really worry too much about it. That's ultimately the only increased demand you have for anything is in micronutrients. Is it ideal to be eating, your 6th bowl of pasta for the day? No. But if that's what you need to get enough energy in to get through, you just got to do it. So I think hydration, cold foods, really helpful. Icy poles, ice blocks. It's why lots of women with HG love like frozen Cokes and things like that, because it's so cold, it kind of suppresses all the sensory component. Smaller and more frequent meals. Lean on things like starchy carbs, salty foods, crackers, dry things. Eat something the moment you wake up, like your eyes open before you're even vertical for the day. Shove something in your mouth, pretzels, crackers, salted cashew, whatever. And don't think that not eating will help your nausea, because as your blood glucose comes down, the nausea ramps up. And the more that you go to correct that with a really high glycemic index food, like a lolly or something like that, you'll shoot it back up and it'll feel really good temporarily, but you'll come crashing back down again really hard. So as difficult as it is, even just trying to smoothen that out. Like I literally said to a client yesterday, like, you can have the lolly, but just maybe have some fruit at the same time if you can manage fruit, because you're managing fruit okay. Even that little bit of extra fiber will just help slow it down a little bit more. You won't crash as hard. So sometimes it's like I'm giving recommendations like that. It's not like it's time to eat 5 serves of vegetables and eat your meat and eat your fish. And people are like, I haven't eaten any like protein-rich foods in like 2 weeks. Like, what do I do? I'm like, it's okay. You're going to get protein from all these other sources of food. So the main like red flags to look out for is, prolonged vomiting, severe dehydration, weight loss. Like if you're losing more than 5% of your body weight, 3 to 5% of your body weight, they're probably the things that you're like, I need medical attention. And also know that you can go to your GP and obstetrician and ask for medication to help with the nausea as well, particularly if it's affecting your life, your work, your mental health. Like, they're there for a reason. So please reach out and get help with that. Some people find things like ginger quite helpful, or vitamin B6. Most prenatal multivitamins are built in with enough B6 to do that for you. So you don't usually have to seek it out, but just depends on what you're using. So they're my kind of key tips, but honestly, it's just about appearance versus reality. Like, you think everyone's having green smoothies for breakfast in trimester 1 on Instagram. Nobody is. They're like eating a dry Weet-Bix and like questioning their life decisions on the couch, feeling awful. Like I think it's that kind of management. And often because people who go through IVF and infertility, particularly the cohort of people that we work with, they're like, I feel like I can't complain. I have to be grateful and not whinge about the vomiting and the nausea because I wanted this. And I'm like, you can still complain. It's allowed. You can want this and complain and acknowledge it is bad. It is bad.
Yeah, absolutely. I remember with my first pregnancy, I was sick with all of mine, but I just remember I used to have digestive biscuits for breakfast, lunch and dinner, and be driving along in my car just with bags of digestive biscuits and then little basins to vomit in. It was horrific. It was not fun, and I did not enjoy it one bit. I was not a glowy pregnant person. So it isn't always a lovely time. It can be really challenging for some people. There obviously are foods that pregnant women should avoid. I would love it if you could chat us through those and just give people a little bit of an understanding as to why we're asking them to avoid those foods rather than just giving people a list and say you can't have it and just it is what it is.
Yes, this is a very big conversation. Particularly at the moment, I'm increasingly seeing influencers just being like, this is my risk profile and I will do what I want, which I can respect. But also when you've got a big profile and it's a public health issue, I have questions. The way that I like to talk about food safety with my clients when I get the opportunity to have enough time to talk about it, when usually we're just like playing whack-a-mole with nausea and food aversions, which is typically the main concerns that they're having in a trimester 1 consultation, is you've got 2 classes of food safety issues. You have a direct toxin, right? Alcohol, vitamin A or retinol. That's why you can't use your tretinoin on your skin when you're pregnant or breastfeeding. Mercury, don't eat the big fish. Those things directly can cause direct toxic harm to baby. That's why that they're out. Then you've got bacteria that have a risk slider. So those most common types of bacteria that we recommend trying to minimize your exposure to, and by saying minimize, I mean you can get exposed to any of these bacteria in some random food that we didn't think of. It can happen. It's not to cause anxiety, but like if you think like this is 100% safe and this is 100% not safe, that's not how it works. There's historical data and what we think is considered higher risk or lower risk, and that's how those guidelines get made. So on the bacteria front, you have listeria. People who are pregnant have a change in their immune function, and so they're at the increased risk of listeria, of getting listeriosis. The second is salmonella. There's no increased risk of developing salmonella when you're pregnant. This is like one of the most common like food poisoning ones. But there is a small risk of a complication of getting salmonella where bubs is affected. And that's why we try and minimize your exposure to high-risk salmonella foods. Then there's some other like peripheral ones, things like toxoplasmosis, so kitty litter and not cooking your meats all the way through and raw foods and things like that. So that's another one as well that you just had a higher risk of being pregnant. They're the main 3. There's some other smaller ones and just general food safety stuff that you need to be aware of. And so the foods that are on that food list are derived from one of those categories of things. That's why it's there. And like I said, nothing is 100% safe and nothing is 100% a risk. And so I'm somebody who loves to sit in like Facebook pregnancy mum groups and read what people are talking about, because it sometimes gives me ideas of what to post on Instagram and stuff and answer kind of people's questions. And some of the most frustrating posts that I see, and sometimes I comment on them and sometimes I don't. Sometimes I just shut up and bite my tongue and fade into the background. But it's often like, oh, I'm really craving a soft serve ice cream from McDonald's. Like, is it really that bad? Like, why do I have to avoid this? Or like, isn't it just better if I have it because I'm craving it, or whatever that kind of language is around that. And I don't have a problem with that question per se. What I have a problem with is then the people in the comments being like, I ate whatever I wanted in my pregnancy and my baby's fine. Oh, our mums didn't do this, blah, 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 blah. All these different, kind of survivor bias type of stories. And I appreciate all that. But whilst it's very uncommon for people to get sick with listeria or get sick with salmonella and it cause a pregnancy-related complication, the risk-reward ratio just like is so off that we just go, let's just be a little bit more conservative here, just in case. And there's probably going to be more data that will come out that will start to make more foods that were on that list off that list and off that list on that list. That's always going to happen. But that's the like 101 behind it as to why that is, why they are there and what their kind of purpose is.
And what about coffee? I always get lots of women asking me about, are they allowed to have coffee? How many coffees are they allowed to have, etc. And obviously, coming to Australia, coffee is like a national hobby and pastime. I'm one of those weirdos, and I don't like coffee, and I don't drink coffee. So I'm not very good at particularly understanding people's obsession with it. But clearly, I'm the one who's weird, and all you guys aren't weird. And so, can you talk to a little bit about why the coffee thing became a bit of an issue, or what was the research showing? And also, are we allowed to have a coffee if we're pregnant or not?
Yes, great question. So it's not about coffee, it's about caffeine, which is commonly found in coffee, black tea, green tea, matcha tea, hot chocolate, sports products, pre workouts, energy drinks, things like that. So caffeine is the potential issue. And so when we know from the larger studies that more than 200 milligrams of caffeine per day seems to be linked with some pregnancy related complications, so small babies and things like that. There's also been some other tenuous data around infant risk for developing leukemia and other things as well. So there's certainly some definite potential downsides of doing more than 200 milligrams per day of caffeine. But I don't know about you, but before I became a dietitian, I had no idea what the milligram caffeine content was of my skinny latte at the cafe. And you probably won't either exactly know what it is, because I think there was a little local audit that was done. I think it was in Brisbane, of 20 or 30 cafes, and they actually looked at the caffeine content of a single espresso shot, and it ranged so much from 60 milligrams of caffeine per shot to 120, 150 milligrams per shot. So it depends on the bean, how it's extracted, this, that. There's too many factors. But what I say is, on average, if we put it in the middle and go a little bit more conservative, you're probably getting about 100 milligrams of caffeine per single espresso shot per day. So you definitely don't want to be doing more than 2. And even 2, like I said, if it's on that higher side, you're probably slightly over. So that's something to factor in. If you're having 4 cups of black tea per day or 2 espresso shots per day, that's probably your max. If you're a mix and matcher, you need to do the maths on that. Tea is about half, so it's about 50 milligrams per day if it's strongly brewed. Chocolate and things are pretty negligible. Hot chocolates and things like that, 5 milligrams, sometimes 10 milligrams. Unless you're eating a whole lint block, it's probably not really worth factoring in that much. And that's really the idea behind it. We're not trying to punish you for how tired you feel and to deprive you of coffee. The idea is really just to protect you from any excess caffeine. There was a study that was published a few years ago that caused a lot of questions and drama. I like to call it drama when my email inbox blows up after 7 years, posts something alarmist about something related to pregnancy and nutrition, with the author saying that their recommendation was that, caffeine's not essential. Why are we even normalizing up to 200 milligrams? Everyone should just aim for 0 kind of thing. But it wasn't founded on any new research. It was just a narrative literature review, and they were like, this is our recommendation, which is fine. They can have their recommendation, but the public health guidelines are still the same as they are.
Yeah. And often women ask how much more they should be eating in pregnancy. Obviously, an old-fashioned thing was, you're eating for 2 now, eat up. And obviously, that's not quite the case. But again, I think people are just so much more knowledgeable nowadays, and they really do want to understand, how much more actually should they be eating, or in fact, should they be eating anything more? Are you able to give us just even a little simple guidance as to how much we would be needing in each trimester, for example?
So in trimester 1, you need no extra energy, just the micronutrients. In trimester 2, you need the micronutrients and extra energy. It's a small increase of about 300, 350 calories per day. That should be coming from protein and grain food groups. And then in third trimester, it goes up to 400 to 450 calories per day. And that, again, protein and grain groups are your priority focuses there. So that's the rough guide of pregnancy nutrition, it does change based on your pregnancy. So, for example, if I have somebody who's starting at a very much lower body weight and they need to do catch up pregnancy weight gain, then it's more. And if I have somebody who's starting at a very high body weight and we're trying to minimize excess gestational weight gain, then it might actually be the same all the way through, for example.
Okay, great. That's really helpful. And obviously, social media, we love it and hate it probably in equal measure. I definitely see a lot of videos and pictures of people showing off their tummy, 7 days after having their baby or 2 weeks after having their baby. And again, I'll have patients asking me, how quickly can I start losing weight, or how quickly should I be back into my jeans? And that seems to be a bit of a trend as well to, can you leave hospital wearing the jeans that you wore before you were pregnant and things like that. And obviously I'm not encouraging of people doing that, but I would love your thoughts. Is that something that you will get asked about? And also, how much extra nutrition do people need to really get breastfeeding established?
Yeah, I think it's a symptom of body image concerns, and also the diet culturiness that has invaded motherhood. It's really sad because your uterus isn't even back to the size that it was 2 hours after you had a baby. Like, it's just not really that possible for most people. And you also need a certain amount of fat stores laid down biologically to establish breastfeeding as well. So I think it's a standard that people comparing themselves to or trying to uphold that is just not feasible for the vast majority of people. And I think the line is that a lot of people will say, "Oh, I just want to feel like my old self, or I want to have some part of my body back, or some kind of autonomy around that, because you were just cohabitating with another human being in your belly for the last 9 months or so." So I appreciate that element of it, but I think realistic expectations. Ultimately, what I say to people around weight management, if they start asking me about it in pregnancy, I usually just say, "Look, have the baby come back to me when you've got a better sense of what this is like, before you start forecasting that you're going to be back at the gym at 8 weeks postpartum. Good for you if that's you, but again, realistically, the vast majority of people, that is not the case." And so I usually say, look, between 4 to 6 months postpartum is probably a good time to evaluate where you're at weight wise, how much sleep you're getting. It's extremely dependent on that, and what your capacity is to actually refocus a little bit more on yourself. Not to say that you can't focus on yourself before that each day in small ways, absolutely. But weight management takes a lot of extra time and energy and effort. And that's going to take a little slice of your capacity pie for the day, as well as being a parent and, working if you're working and all the rest of it. So I usually say to people, around 4 to 6 months is the time to consider it. Before then, I think you're dreaming. Your body will just do what it's going to do, genetically speaking, and such is that. From a breastfeeding perspective, the other concern is that if you're in quite a significant energy deficit, you just won't be able to support breastfeeding. And many people are shocked to know that breastfeeding actually requires more energy, and even in some cases more micronutrients than pregnancy itself. So you need 500 to 750 calories extra on top of your preconception nutrition per day to establish and support breastfeeding, because it is literally an energy burning activity. You need more fluid because you're losing more fluid. You need to make sure that you're getting enough sleep. How do you do that with the baby? Very difficult. There's so many aspects to it. Your feeding routine, your latching, and lactation consultants are the people to talk about that supply and demand kind of ideology. But my point is I think a lot of people go down this rabbit hole in breastfeeding and trying to establish breastfeeding, of lactation cookies and teas and products. And I feel a lot of the times, and I'm saying very generally speaking, I feel like sometimes some companies can be quite predatory in preying on people who are quite vulnerable, who would do anything to establish breastfeeding and to help. And, you'll get these awesome reviews for these products, which is great that it's helped them. But I also wonder how many of those women were just eating their fourth piece of Vegemite toast for the day, not eating enough, and then they're eating 3 or 4 of those lactation cookies, which will be high in energy. And yes, they'll have brewer's yeast and oats and fenugreek in them and all the galactagogues that are meant to help you turn into a milk machine, whatever that they're promising. But ultimately, I just think it's a caloric issue above everything else. And those things are like little cherries on top once the caloric issue is fixed. And so I think that is a common kind of like competing interests that women will have. They'll come to me, I really want to breastfeed, or I'm having issues with breastfeeding, but I'm really dissatisfied with my weight at the same time, and I'm not sleeping. And I'm like, okay, well, we're not going to be able to do all these things simultaneously. You're coming to me, there's no miracle pill that fixes all these things. So we need to, what's your priorities here? Like, let's talk about them genuinely, and let's make a phased approach. I worked in a postpartum clinical research study, and we would see women for postpartum nutrition counseling at 6 months, because that's when they could kind of come up for air, baby start some solids, and not as reliant on you as they were, a few months ago. And they can start to actually see themselves a little bit more separately to the baby. They can give the baby to creche and go and exercise if they want to, and things like that. So that is really tricky. And I think society, social media, diet culture has a lot to answer for applying this kind of pressure to new parents. It is so, so gross. I hate it. I hate that pressure.
Me too. Me too. And in terms of hydration, I often find a lot of breastfeeding mothers don't actually drink enough fluids, and
Yeah.
they're completely dehydrated. Sometimes they end up with urinary tract infections. My tip is always to say, whenever you sit down to feed, have a large glass of water right beside you and try and drink that as the baby's drinking. Think about that you're replacing that. But do you have any sort of markers of how much hydration someone should be having an average if they're breastfeeding?
So the general recommendation is 2.8 to 3 litres per day. And the easiest way you can check is just look at the color of your urine. So urine should look like champagne. If it looks darker than that, you're not hydrating enough. If it's like water, then you're probably overhydrated. Most prenatal vitamins will temporarily make your wee look about fluorescent yellow. So ignore the first wheeze after your prenatal vitamin. Look later in the day. And if it's any darker than champagne, you're probably underhydrating or dehydrated.
And sorry, the last thing that I want to ask you along this journey is women who end up with postnatal depression. And what do you think the role of diet might be in the treatment of women with postnatal depression? Do you feel we should be bringing the dietitian in and involving them with that patient?
Yeah, that's a great question. Postnatal depression obviously is common, and for many people quite debilitating, or sometimes they're a bit shocked that they have that diagnosis. Obviously, mental health support is your kind of first stop, and making sure that they're medically safe and all those kinds of things. But looking broader, a lot of the work that I do in P&D is actually before people are even postpartum. So I actually prepare all my clients for postpartum and breastfeeding whilst they're pregnant. I find that generally speaking, once they go on maternity leave, they have a little bit more time, they have a little bit more energy to think about it. Not energy as in energy, but like mental space to think about it. And a lot of the strategies we actually embed, we don't even necessarily call them out, but we're thinking about all these things in the background. So, for example, one of the main things that we really focus on is iron status. Iron status in pregnancy notoriously drops off because of the rapid expansion in blood volume. Your iron status is one of the biggest nutritional links to your risk of postnatal depression. So we need to make sure that in your pregnancy, as much as possible, we're maintaining and improving your iron reserves, and that as well, not knowing how much blood you'll lose at birth or postpartum, that we're trying to set you up as well as possible so that you're not left deficient. A lot of people in trimester 3 will become quite deficient, and you cannot out supplement it quickly enough. So typically then we need to look at things like iron infusions and things like that. We advocate a lot with our clients for these, because just looking at timelines, you just cannot correct. It doesn't matter how much iron supplement you take, you're not going to get in front of that runaway train now. Like, it's kind of past that point. And that is probably one of the biggest factors. Other things are omega-3 status. So we at the Dietologist, we supplement everybody pretty much with omega-3s preconceptionally, in pregnancy and postpartum. So that's another factor that we look at. And also B vitamins. There was also a more recent study, it was very small though, around the Mediterranean diet being helpful and preventative, and that the hallmarks of increased risks of PND were higher red meat intake and processed meat intake as well. So that's something as well to factor in. I think though, I think it can be used in the context of somebody's received a diagnosis of PND, but I think realistically speaking, if I'm speaking from like a realistic lens, I'm not sure if somebody with postnatal depression who's struggling, seeing their doctor, seeing their psychologist or counsellor, is going to have the space mentally to see a dietitian and actually work on their nutrition. Because like I said, I can't eat the food for you. So I'm not sure if it's just going to feel like more homework. And so a lot of the work that we do is beforehand to try and mitigate risks based on the data or associating deficits in those nutrients and PND, more than anything, because I actually find people with postnatal depression generally will withdraw. They'll pull out. They're not going to, then they don't step forward, they withdraw. So it's not that it shouldn't, or we can't, we absolutely can, but realistically speaking, people disengage. They don't engage at that point.
Absolutely. And that might be for anyone listening. If you are the mother or the friend or the sister of someone who's recently had a baby and you're worried about them from a mental health perspective, that might be something really practical that you can do to help that person, you know, not specifically saying, would you like me to make you a meal, or would you like me to do some shopping? Just make the meal, make something really tasty and nutritious and take it round. The person's unlikely to reach out and ask for you to help, but they probably would be amazing if you did. And Steph, you have been amazing. I know that this conversation in no way replaces coming and having a personal consultation with you or any other amazing preconception dietitian, but thank you so much. You've taken us on an amazing journey. I wondered whether you had any resources that you think are particularly helpful that you could direct our listeners to, and then we'll make sure to put those details in our show notes as well.
Yeah, absolutely. Our favorite, and everybody's favorite, is our preconception lifestyle checklist, which is free and available to download. It's one page about why it's important, one page for women and one page for men, for those who are trying to conceive with a man. If you're not, like somebody messaged me this morning being like, I have a female partner. I'm like, just bin the last page. Don't worry about it. You don't need that. I was like, you're getting the good sperm from the fertility clinic. You don't need that one. So that would be probably my go-to for preconception. If you're looking for more just general kind of tips and broader stuff, things like IVF, fertility, pregnancy, postpartum, then I would recommend giving us a follow on Instagram at @the_dietologist. We're super active there. There's like 1,000 posts. There's lots of things to learn. Our blogs are really helpful as well, which are easily searchable and categorized. So it's thedietologist.com.au to find our blog, and also our podcast, Fertility Friendly Food, which we've just wrapped up, but there's still 120 episodes that you can go and binge listen to. So if you already listened to this podcast, you like podcasts, go and find those. And if you don't know, and I get this question a lot, but in Spotify, when you go to the podcast page, if you just pull the page down slightly, you can search keywords in that podcast's titles and streams. So if you've got PCOS, you just pull down, type in PCOS. You've got endo, you pull down, you type in endo, and all the podcast episodes relating to that topic will pop up. So just a little life hack for everyone.
Thank you so much for giving me your time today. It's been so helpful. I'm sure our listeners are going to really, really enjoy this episode. And I'm hoping that maybe in the future you'll come back and we can do a bit of a deep dive into PCOS and endometriosis.
Yes, sounds awesome. Thank you for having me, Shauna. It's been a pleasure.